Good afternoon, ladies and gentlemen, dear colleagues. First of all, I'd like to thank the Turkish Continent Society for inviting me to be here. It's a great pleasure for me to be here, to come again to this country, which I like it very much, and to meet all friends, which I met some few years ago. I'm going to present on the role of causes other than prostate enlargement in treatment failure. But I'd like to address first that in the past, as you know, we used to consider BPH, which is a pathological diagnosis, as the main problem for lower urinary tract symptoms. But was a Danish urologist that in the early 90s introduced the concept of clinical BPH, showing that some men might have lower urinary tract symptoms without being obstructed, or even might have a small prostate gland, like those patients with urethral stricture, or some patients might have obstruction, prostate enlargement, and even without symptoms, as those patients with chronic retention who do not express symptoms. And this is due to the fact that, as Francisco Cruz and has been previously shown this morning, there are other symptoms, other problems involved in the development of lower urinary tract symptoms, not only prostate enlargement, but also metabolic causes, etc. And the EAU has established clear guidelines depending for medical and surgical therapy, depending in regards to medical therapy, mostly on the presence of storage symptoms or predominant voiding symptoms, and also depending on the size of the prostate. For those patients with bigger prostate glands, so the recommendation when there is a risk of progression is the use of 5-alpha reductase inhibitors. And we know all this aging has been shown by Francisco Cruz. We know the mechanism of action of 5-RI, alpha blockers, antimuscarinic, even vasopressin. We know how these drugs work in reducing lower urinary tract symptoms. But these drugs are not free of side effects. And in fact, side effects are quite often the main reason for patients to quit therapy. In fact, only 30 to 40% of patients continuing with medical therapy once we prescribe any drug. And only 9% of patients continue in the long term with combination therapy, let's say 5-RI and alpha blockers. So one of the main reasons why patients do not continue with therapy or express failure to therapy is related to side effects. But also there are some other reasons for treatment failure. For example, the density of alpha receptors in the prostate gland, the mRNA expression of alpha receptor, the epigenetic modification through methylation pathways, age of body mass index as shown by Salvador Arslandin, and also polymorphism of the 5-alpha reductase genes associated with post-5-RI treatment chain in volume and IPSS. So metabolic syndrome is an important reason for failure. Metabolic syndrome, as described as the combination of abdominal obesity, elevated serum triglycerides, lower HDL cholesterol, increased blood pressure, and high level of fasting plasma glucose, so has been shown to be responsible for treatment failure, not only medical therapy, but also surgical therapy. In fact, there is a growing body of evidence suggesting that patients with metabolic syndrome do not respond so well to medical therapy, but neither to surgical therapy. In fact, metabolic syndrome also allows patients to respond not so well, not only for BPH therapy, but also for surgery for prostate cancer. In fact, patients with metabolic syndrome do not do so well after radical prostatectomy. There's a growing body of evidence in regard to metabolic syndrome, and this is why we should consider not only drug therapy, but also diet and exercise at the time of prescribing any drug to our patients. But the pathogenic is related to genetic factor, fetal programming, dietary intake, lack of exercise, through several mechanisms like insulin resistance, visceral obesity, HPA dysregulation, or dyslipidemia, leading to the presence of metabolic syndrome. And metabolic syndrome through several mechanisms like insulin resistance, hormonal changes, pelvic atherosclerosis, or inflammation through the release of cytokines might promote lowering tract symptoms related to metabolic syndrome. But also ischemia might be one reason for lowering tract symptoms. It is well known that ischemia might be responsible not only to promote lowering tract symptoms related to BPH, but also the Trussor failure or the Trussor overactivity as described by Elia Abadi in pathological study in the early 90s. And we also know that the progression of prostatic growth might be the result of multiple factors that are not targeted with the current therapy. So it's clear that the high volume of inflammatory infiltrate in BPH tissue might be responsible. It has been shown. Cytokine release as driving factor in epithelial and stromal proliferation. We also know that a higher level of prostatic inflammation has been associated with larger prostate and higher IPSS score. And also it's clear that patients with prostate inflammation are at higher risk of acute retention of urine, as has been shown in the MTOP study, medical therapy of prostatic syndrome, the famous study evaluating combination of FRI plus alpha blocker versus monotherapy or placebo, and also in the REDUCE. So it was clear that patients with prostatic inflammation are more prone to have retention and do not respond so well to medical therapy. So the problem is that we don't know what, although there is some evidence suggesting that this is the case, and that there are some anti-inflammatory compounds that might allow the patient to respond to or to improve lowering tract symptoms, there is not a clear therapy at this stage. And this is why in this algorithm proposed by Curtis Nickel, based on epidemiological studies, on identifying biomarkers of inflammation, we might, after identifying possible drugs for targeting inflammation and conducting randomized trials, we might obtain some information regarding the utility of anti-inflammatory drugs in the management of those patients who do not respond in the proper way to medical therapy. So not only the size of the prostate, not only the tension of the bladder outlet or the contractility of the detrusor. So we also have to think and be aware that prostate inflammation might be one of the reasons for patients not responding to medical therapy. So this might be for the future, but in the meantime, as Francisco Cruz said, we have to rely on medical therapy with any one of the possibilities that is shown in this slide, monotherapy, a combination with any one of the combination we have here, and those patients who do not respond to medical therapy, we have to consider surgical therapy at the proper time. So now there is a trend to consider that we continue to do the same surgery, but we do the surgery later on. So if patients do not respond to medical therapy, then we have to do something else, and what we have nowadays is surgical therapy. And we'll have the discussion later on minimal invasive therapy. Thank you very much for your attention.